Hello everyone, my name is Marissa H OW, and this year I'm doing plastic surgery. So a little bit about me, I'm a senior here at Frisco High School, and I plan to go to Texas A&M. I got into their engineering school, and so I plan to major in biomedical engineering there. I'm a second year student for ISM, and I'm also a dog lover. People compare me to like a proud mom of their child because like I'm obsessed with my dog, so that's kind of why. She's adorable. Okay, so my first year in ISM, I studied pediatric endocrinology, which is the study of hormones within children. And my mentor was Dr. John Oden, which is also my doctor because I'm a type 1 diabetic, and so that's kind of why I went into that field. For my final product, I studied the correlations between type 1 diabetes and cardiovascular disease. And that's my mentor me, or last year's mentor me, and I don't know grammar. And so this year I'm studying plastic surgery. Last year I was in health science too, and so I got to rotate throughout the different parts of the hospital, and this year I want to learn more about the OR because I found that really intriguing last year. And so I'm also doing plastic surgery, and so my quote is, you can't help everyone, but everyone can help someone. And so why I chose plastic surgery? Plastic surgery, a lot of people seem to think it's a very vain surgery. Or a very vanity surgery, but it's actually the process of reconstructing or repairing parts of the body, especially by the transfer of tissue, either in the treatment of injury or for cosmetic reasons. So it's not just for like aesthetically pleasing reasons, it's also for like people like burn victims and like other people who have like amputations and scars. I believe that people should have a choice on like how they want to look, that they shouldn't be always with a scar on their face just because they got into a freak accident. They should have that choice if they want to look normal again. And then also with plastic surgeries, many surgeons have families, and that was something that I really wanted to look into because I want to start a family when I'm older. And so plastic surgery, most of them, if not all of them, have families. And so I had a ton of interviews. My first one was with Dr. Greenberg. He was actually a OBGYN, which is like a baby doctor in a way, and he was a cosmetic surgeon, and most of his like patients were of his previous surgeries. So like if he had a mom give birth, then his patient would be like a tummy tuck patient and stuff like that, and he had his own private practice at Centennial. My other interview was with Dr. Brost, and he was a facial surgeon. He told me that he wanted to be an ENT, which is an ear, nose, and throat doctor. But then he kind of like went into the path of plastic surgery, so he likes doing facial surgeries. He likes to do complicated nasal surgeries, so it's not just like nose jobs all the time, rhinoplasties. It's also like if people have a deviated septum in their nose and they can't breathe, he'd be able to fix them. And he also has a private practice. One of the other doctors was Dr. Chong. He was at UT Southwestern, and he was one of the first doctors I interviewed from a hospital. And he did traumatic reconstructive surgery, and so if a patient, he told me that there was a patient that like got into a freak accident and had like their arm almost cut off, and he like reconstructed that. He also told me about one of his patients that had like a 23-pound tumor that he had to remove and make look normal again. So that's something that really interested me, and he works in UT Southwestern. Another doctor is Dr. Thornton. He specializes in reconstructing people with skin cancer, and so if people have like malignant melanoma or skin cancers like that, the dermatologist will normally just like take out a hole of their nose or wherever the little mass was, and they'll have a protruding hole in their face, and what he does is he fixes the hole and makes the skin area look normal again. And so I thought that was really interesting. He gave advice about college. He has, I think, 7 children. So he was really good at giving advice about college. Yeah. And he works in a hospital setting. He also works at UT Southwestern. He was nice. He was very humble. He told me that he doesn't look at his paychecks. He just like goes with it. He doesn't care about the money. He's just happy that he's helping other people. And then I also interviewed Dr. Kinkle. He's a professor at UT Southwestern Medical School. He's also like kind of the head of plastic surgery at UT Southwestern. And he works on like body contouring, so if someone is 400 pounds and they want to go back down doing bariatric surgery, he fixes the way that their body, because normally you'll have like skin flaps, he'll fix it. He works in both academic and hospital setting, which he told me that it kept him on his toes, and so he was a really good interview. And then I interviewed Dr. Kane. He's a craniofacial reconstructive surgeon, and that's kind of like what I'm interested in as well. It's like when little kids have like cleft palates or like their head is shaped, their skull like fuses in weird ways. He's able to fix them, and he was very straightforward and educational. He kept me on my toes, like I had to watch what I was saying and say in the proper way. And he works at Children's. My other interview was with Dr. Nahara. He told me he was like the bread and butter surgeon. He did 50% cosmetic and 50% reconstructive. He told me that the morals were a huge part of the field because you don't want a plastic surgeon that just went into surgery for the money, because that's where you hear all about like the botched plastic surgery. And he was in the private practice at Centennial as well. And then my last interview was with Dr. Smart. He was a craniofacial reconstructive surgeon. Dr. Kinkle recommended him to me, and so he was extremely young, and he was laid back, and he loved his job, and it was a hospital setting. And then my mentor is Dr. Stiles. She's the only female I interviewed. She cared thoroughly about her patients, and she made a point about the mental state of her patients, which made a lot of sense because you don't want a patient that is mentally unstable going in for cosmetic surgery and they're not going to be happy and they're just going to keep doing it. So she made a really big point about that. And then I did research a lot. This is the information I gained from a bunch of different articles. The first one was Education in Plastic Surgery, Are We Headed in the Right Direction? And on the picture on the right is kind of like what Dr. Thornton does, where he has like a huge gaping hole right there. He'll be able to fix it and make it look like the picture on the right. The training is starting to become more demanding on the person. Residency, throughout all the doctors I talked to told me that residency was the hardest thing to go through, and not to have a family during residency because it's very, very demanding. It's also, plastic surgery is becoming more accepted across the globe, and residents mainly focus on reconstructive and not cosmetic, which is something a lot of the different doctors told me that were doing also cosmetic surgery. They were like, I really didn't learn this in residency. I had to take like an extra like year of fellowship to learn about more cosmetic. And advancements are being made in plastic surgery, so that means less scarring. Botulinum toxin to improve results in cleft lip repair. People with cleft lip, their lip like goes like that, and so you normally have a scar above your lip, and it's very noticeable to talk because it's like really tight. Well, botulinum toxin is Botox, and it like releases the tension, and so it's easier to talk without that little like stress right there. It decreases the wound tension, and also what I found interesting was ethnicity seems to play a part in the role of the toxin. So this is also a new study too, but it's there. Facial feminization surgery, surgical techniques. I'm really interested in surgical techniques because I want to know like what's the best way to get to the end product. And so the case study, it was a case study regarding facial plastic surgery for women. All women had been previously diagnosed with gender dysphoria, which is gender identity disorder. So they wanted to be a woman, but they also had mainly features like a very like chiseled jawbone and stuff like that, and they wanted to lighten it up and have more feminine features. And there were a lot of success stories because the surgeon chose the best way that they could go, not just by the books. So that was kind of interesting. And then the robotic microsurgery. I talked to Dr. Chong about this, was a robotic surgery, and he told me about that it's good for only microscopic surgery essentially, because with plastic surgery you need like a way to like move carefully, and like it's like a fluid like motion, and with robotic surgery it's very like cut and precise, which is also good, but you also get like that weird non-contouring look. And so that was the microscopic surgery. It's when you're like repairing like blood vessels, and it's very hard if you just like look down, like blood vessels are super tiny, and so the robotic surgery. And during this study, it was more time on the machine lead to increased ability to navigate. And that movie, or like that thing, is really long, so we're just gonna skip it. All right, so what can I take away from the research and interviews? I really like the idea of reconstruction. I like the idea of helping other people, and I also have a strong interest for scar revision. So I try to go off of that. So my original work, I did a research over keloids and scars. So a keloid is a scar that doesn't know when to stop. Ooh, spell check. They do not subside over time, and they're red and tender. And these pictures can also be very graphic, little heads up, but that's what a keloid looks like. Most of the time, keloids are from ear piercings, and so if someone gets an ear piercing, you can get the thing on the bottom left. So, and then that's like what it turns out to be, and it's extremely painful too. So, yeah. I did notes over 2 cases. Due to HEPA, I can't really like tell you like their names and like what identifies them completely, but I can kind of give you like a little backstory. I also couldn't use their pictures, so I just found something that I saw that was similar online. The keloid scar on this first patient, it was a male. He was 40. He was also African American, which apparently ethnicity plays a part in keloid formation too. So keloid scars of the ear, of the ear are bilateral, and so he had ear piercings since he was 8, and ever since he was, I was reading the file, and he grew up in like Africa, and like you can't have like ear piercing, and so like ever since he was 8, he like had to take him out at school, and they eventually closed up, and he had to get him re-pierced, and then closed up again. He had to get him re-pierced, and finally he had keloids in both of his ears. So they were bilaterally. It was like a little dumbbell shaped right there. He had symptoms of pain, itching, and tenderness, and he went under several Kenalog shots, and Kenalog shots are to like help prevent keloids. Keloids they were resected and treated with radiation, so most of the patients treated with keloids do go through radiation treatment as well, and if you do, it's more likely you'll be successful. He did have a family history of keloids, so it kind of makes me think that keloids are also hereditary. This was the 3rd time getting his keloids resected, and he had a total of 6 radiation treatments because they were so like, they were huge. Like I saw a picture and it was like up on his face like that, so it took a while for it to go away. They were dumbbell shaped, and after the surgery the keloids disappeared along with the radiation therapy, and so that's kind of like what it happened. And also he had a little keloid in front of his ear too, and so like a little dumbbell, but it's all gone now. And then the second patient, she was a female, and she was 55. She had a hysterectomy done, and so she had keloid scars on her abdomen. The patient did not want a surgical treatment at the time, and so she tried 3 different option treatments. You could have scar healing band-aids, which you have to put on for 20 to 23 hours a day, which comes into the problem with compliance with patients, because wearing a band-aid for 20 to 23 hours a day is not, patients normally don't comply or won't be compliant with that. She could have 3 Kenalog shots 6 weeks apart, or she can have excision of the scar and injection of Kenalog at the same time, which is surgery. She tried a metformin band-aid and ended up it not working, and so she wanted surgery. She underwent surgery and then had 1 treatment of radiation. She received 3 Kenalog shots and is only seen as needed. And so on here, the top is like a keloid of what hers looked like, and at the bottom she had a vertical incision on her abdomen, and so that straight line was full of keloids, and so it was very painful to put on like pants because you would have it rubbing all the time, but they were able to remove it, and it was like it covered up almost like half her stomach. If you divided her into 3 sections, it was like the middle section was full of keloids, so it was extremely painful. And then my mentor gave me research articles to like look over. And so the first one was Reconstructive, a randomized control trial of the Embrace Advanced Scar Therapy device to reduce incisional scar formation. So for the incisional scar formation, you have a big band that you like put on your scar, and you wear it for, I think this was a 12-month trial. You wore it after you had surgery. You had to put it on right after. You couldn't wait, so this can only be used with newer scars. You could tell that they only put it on half of one side of the scar, and half of the other they left with like controlled treatment, so like normal like creams or like nothing at all. And so they used it like that, and after the 6 months you can like tell significantly that it was extremely treated, like the Embrace scar treatment worked. And then after 12 months you can tell that their scar with the Embrace treated it, like compared to the difference. So the coloration went down, the size went down, the scar tissue formation under it went down, the tension went down too. So it, there we go. Patients and physicians saw drastic changes on how the scar healed, and the patients underwent abdominoplasty, so like a tummy tuck, and so that's why the scar looks like that. And it was 12 months post-op. There we go. Analysis of the surgical treatments for earlobe keloids, analysis of 174 keloids in 145 patients. So most of the patients, or a lot of the patients, had like double keloids. Keloids are mostly commonly seen on the earlobe masses because the characteristics of the earlobe, such as the anatomic free edges, arc shape, and lack of cartilage. And so it's important to use like appropriate like surgical modalities. Post-operative radiation therapy and self-management are very important to like prevent a reoccurrence of a keloid. And so like those are some keloids on the ear that can form from just simple piercings. It starts out like really hard, and then it just gets more like flustered and big, and then it ends up turning up like that. And they're able to make the earlobes, after having such a huge mass, turn up to look like a normal earlobe right there. And then my other article I researched was the treatment of traumatic scars using fat grafts mixed with platelet-rich plasma and resurfacing of the skin with the 1540 nanometer non-ablasive laser. Okay. Patients were divided into 3 groups. There were 60 patients in all, so 20 per group. And in Group A, they were treated with fat grafts mixed with PRP, which is the platelet-rich plasma. And in Group B, they were treated with the non-ablative laser. And in Group C, they were treated with both procedures. Group C had an increase of 22% in wound healing compared to Group A. And then Group C had an increase of 11% compared with Group B. And so the laser alone was better than just like the fat grafts, but mixed together, they were able to take a traumatic scar on someone's face and turn it into just very little scar. You can even see like the tension on the face is not as bad as it was before. And that was 6 months. All of this research will help me understand how the scar heals and what's the best way to approach scar revision. And so in my final product, I kind of want to have a patient that needs to undergo scar revision, scar like healing because of a keloid or a massive traumatic injury. And I want to be able to understand like why a physician does it this way and what's the best way to go for a specific scar. And so all that research will help me. In the future, I plan to observe and learn more from firsthand from my mentor. Also, I want to create a stronger relationship with doctors within the field of plastic surgery. It's a very competitive field, and so knowing people within the field will help me. And then I want to be able to learn to my full potential and not feel like I'm holding back on anything. So that was my research speech. Thank you for everyone that was listening.